To all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar, or you can sign up for our email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. For all athletic trainers who are intending to get live CEUs from the VOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website tomorrow. Dr. Joseph Snavely is an orthopedic spine surgeon who completed his bachelor's degree at the University of Central Florida, medical degree at the University of Miami, orthopedic surgery residency at Orlando Health, and fellowship in spine surgery at Northwestern University in Chicago. He is active in research and has authored peer-reviewed publications and presented at the international, national, and state levels. He will be speaking today about cervical spine injuries in athletes. Now, I'll have you take it away.
All right, thank you, Michelle. Glad to be here today, giving this talk to you guys. I think we have kind of an open question and answer session, during the talk. So just go ahead and chat, any questions you guys have, and we'll try to get to them as we go through the talk. So today we're basically talking about injuries to the cervical spine in athletes. And these are from, professional level athletes down to your everyday weekend warrior and, adolescent recreational athletes. No conflicts of interest to disclose. So cervical spine injuries account for about 2 to 3% of all athletic injuries. These can, result in players missing games and more serious issues of chronic pain, possible disabilities, and the worst case scenarios, permanent neurologic injuries. Gymnastics and ice hockey are actually the highest incidence of cervical injuries out of all sports. But obviously when we think about the bad injuries, those are typically football. They're the highest number of catastrophic injuries and the highest number of injuries in organized sports games. When we're talking about recreational injuries or injuries just, most likely with people goofing around in swimming pools or lakes, diving is going to account for the majority of these types of injuries. So there are about 10,000, and actually that number is a little low. That's an older number. Now more about closer to 17,000 cases per year of spinal cord injury in the US, and between 7 to 9% of those occur at athletic events. 10 to 15% of football players will encounter some form of cervical injury during play, but most of those will be minor injuries. Football stats specifically, about 0.6 to 1.4 athletes per 100,000 will have some kind of permanent injury from a cervical spine injury. And 50% of college players that they studied back in 1976 who reported a previous neck injury ended up showing some kind of changes on their x-rays, whether that was an old fracture or degenerative disc. Different types of injuries that we'll be going through. The nerve root and brachial plexus type injuries, such as burners, stingers, those types of things. Cervical strains and sprains, acute disc herniations, transient quadriplegia, congenital anomalies like Clippable file syndrome, and then unstable cervical fractures and dislocations. So starting out with nerve root and brachial plexus injuries, stingers and burners are very common. We've all probably seen them covering, athletic events. The most common, type of injury will be just a transient brachial plexus injury. And these are typically associated with contact sports. Half of college football players will see an injury like this, and that number is probably even higher. Actually, that was from back in 1979 that stat was put out. Unilateral symptoms are most common. Anytime a player has symptoms going down both arms, that should be a red flag that there should be further workup for a potential spinal cord injury, and that may appear on your quiz later. Actually, typically these will be just a sensory issue, but sometimes it will result in pain and motor weakness, usually in the distribution of the shoulder girdle, sometimes going further down the arm. Again, usually these are sensory in nature, pain, numbness radiating to the arm and hand, C5 and C6 dermatomes, so the deltoid, biceps, and then the rotator cuff will be the most affected areas that you see the weakness at, if there is any. And that is because there is some increased mobility at the C5 and C6 and C7 levels. And when we're looking at degenerative issues in spine surgery, those again are the most common levels that wear down for the same reason, because there is more mobility at those levels of your neck. Relatively short duration of pain for most of these types of injuries, lasting between seconds to minutes. When they last longer, or there's any kind of persistence of weakness, that again is a little bit more of a concerning finding. There's a couple different mechanisms here that this can happen. There's the brachial plexus stretch mechanism, which is when a player has a hit to their shoulder and that's compressed, and then their neck is stretched in the opposite direction of the affected arm. And that's usually seen in more amateur athletes or younger athletes because of weakness around that shoulder girdle. The nerve root compression mechanism is actually when the neck tilts towards the side of the affected arm. And that's basically the neural foramen where the nerve root exits, closing down and pinching on that nerve root. You can see this a little bit more frequently in patients with foraminal stenosis pre-existing. This is more commonly seen at college and professional level athletes or football players. Treatment for stingers and burners is usually just watching and waiting. They can usually return to play, if not the same game, within the next week, as long as symptoms have resolved. But they do need to have completely pain-free range of motion of their cervical spine and a normal neuromotor exam. If symptoms are lasting for more than 3 weeks, or there has been more than one of these types of episodes, you do need to look a little bit further, usually starting with an x-ray to assess for any kind of fracture or instability. And sometimes we'll work it up further with an MRI depending on their symptoms. You can even consider doing nerve testing with an EMG or nerve conduction study. And again, if it's one of these things where the patient has had multiple episodes, you're going to want to be a little more hesitant about letting them go back until you've ruled out anything on MRI or x-ray that could be making them more susceptible to these types of injuries. And again, they have to be pain-free, have full strength, normal sensation, and normal evaluation. So things to consider if someone just keeps getting these types of injuries. There are, for football players, what we would call cowboy collar, or basically higher shoulder pads with a cervical roll behind it, just to limit that neck flexion and extension a little bit. Probably needs to be something that the coaches are going through their techniques and trying to fine tune and find areas that they're not, blocking or tackling with the proper technique. That can be something that can be focused on in their training, is strengthening those neck and shoulder muscles. And if this is something that continues to be an issue, either changing the player's position, usually from a defensive position to something offensive, or just changing sports. Moving on, strains and sprains are also pretty frequently seen injuries. Strains are going to be a muscular injury that typically presents with pain and a normal neurologic examination. Usually when someone presents with neck pain, they're going to go ahead and usually be evaluated with an x-ray if this is any kind of, if there's any severity to their symptoms or any persistence of these symptoms. And so a strain is basically, a diagnosis of ruling out anything abnormal on x-ray. And as long as it's, seems to be muscular, that's usually going to be the diagnosis. You would manage this with NSAIDs, massage, physical therapy, sometimes immobilization, depending on how severe their symptoms are. Sprains are going to be more ligamentous based, or involving the facet joint capsules along the posterior aspect of the spine. More minor sprains will be, typically seen with similar symptoms and evaluation findings as you would see with a strain. This is going to be something that there can be a much more major, I guess, effect if it's a serious injury than you would see with a strain, however, and a lot of the times immobilizing these patients is required. If there's any kind of posterior ligament disruption, which you would see typically on MRI, that can be something that eventually may need surgery and potentially a fusion, depending on how much instability or posterior ligamentous injury there is. Traumatic disc herniations are probably a little more rare, and that's going to be something where you're going to see primarily neurologic issues, whether that's radiculopathy going down the arms, or in more serious cases, you might see a transient or even permanent quadriplegia. An MRI is obviously going to be needed to diagnose a disc herniation. And if there's any kind of neurologic symptoms like that that are persisting, there's a good chance that you're going to find not only a disc herniation but other issues on the MRI. These still, unless we're talking about a permanent issue, typically if it's just a radiculopathy where it's radiating down the arm, these will typically resolve on their own. If it's, again, a persisting or a more serious issue, it can require surgery, which would usually be from an anterior approach involving a discectomy and fusion. This is just an MRI example of what you might see if you were looking, at a traumatic central disc herniation. So transient quadriplegia, this was first described by Torg, who you're going to see that name come up a little bit more in this talk. And he was one of the first physicians to study these kinds of cervical spine injuries in athletes. Symptoms of transient quadriplegia usually involves pain, like a burning pain or tingling, or even numbness in the arms and legs. This can be anywhere from ranging from mild weakness all the way to like a complete paralysis. Typically, for it to be a transient quadriplegia, symptoms will resolve, usually a lot sooner than 24 hours, but they can last up to 24 to 48 hours. X-rays are typically negative for any kind of fracture or dislocation. You may see stenosis or Clippable syndrome, which we'll get into further later in the talk. Or there may be degenerative disc disease or a disc herniation seen on imaging. The mechanism for a transient quadriplegia type injury can either be a hyperextension mechanism where the neck extends, and that would typically be, I can get my hair to show up, pinching of the spinal canal between the vertebral body above and the lamina below, or a hyperflexion injury where you would expect the spinal canal or the spinal cord to kind of drape over anteriorly, and especially if there's like a disc herniation or something there, it could impinge on that. Dr. Torg studied 110 athletes back in the day who had transient quadriplegia. 63 of these athletes actually returned to sports, and 35 of those 63 ended up having an additional episode. Nobody in this study had a permanent neurologic injury, but there was a correlation of stenosis in these players experiencing transient quadriplegia. Basically what they concluded was that recurrent episodes of this did not actually predispose athletes to a permanent neurodeficit, despite it being a scary thing to see or for the player to go through. There was really no contraindication to return to play after transient quadriplegia as long as the patient had a complete neurologic recovery, they had normal cervical motion and no instability on imaging, and as long as there was no absolute or functional stenosis on MRI or CT scans. There was a disc herniation seen on MRI in a patient with transient quadriplegia. That was noted as a relative contraindication. There was spinal stenosis that was determined to be an absolute contraindication. And so in a player where they're getting these symptoms and an MRI shows that they've got stenosis, that's usually going to be something that we got to stop them from playing a contact sport, whether that's football or hockey, really most high level sports. Cervical stenosis is defined as a AP diameter of the spinal canal, less than 13 millimeters on a lateral radiograph. And honestly, most of the time we're diagnosing stenosis based on MRIs, but Torg initially studied it based on findings on lateral x-rays. So the torg ratio, this was a very popular determining way to determine spinal stenosis or cervical stenosis many years ago, and that was defined as a ratio number of less than 0.8 when comparing the spinal canal, or basically this spinal laminar junction here that you see marked as A, over the vertebral body size B. So the problem with this torg ratio was that especially football players, big guys, tend to have bigger vertebral body size. And so these guys would have a huge vertebral body and a normal size spinal canal, but that ratio number ended up being lower in a lot of these asymptomatic players without any issues. And so this kind of got ruled out as a effective means of determining cervical stenosis. Functional stenosis is more determined on like an MRI or a CT myelogram, where you can really define the spinal cord, the spinal canal, and how much spinal fluid is surrounding it. In players where there is noted to be no room for the spinal cord and no reserve of CSF around that spinal cord, that was defined as a functional stenosis. And again, in players exhibiting symptoms, that was typically an absolute contraindication to return to contact sports. So again, that torg ratio number, less than 0.8, not too effective in determining spinal stenosis. 93% of players who had transient quadriplegia were found to have that ratio less than 0.8, but 48% of asymptomatic, totally fine football players also had that ratio less than 0.8, and 12% of asymptomatic non-athletes have it. So really is a poor screening instrument. It's kind of been ruled out, but just for historical purposes, it's a number that was very important in the past. And that might show up in your test as well. So spear tackler spine, this is something pretty much limited to football players. And this is a kind of a multitude of findings that are going to end up being something that we're going to say this player cannot return to football. Typically, it's going to have underlying congenital stenosis of the cervical spine, and then you're also going to see them having a lack of lordosis. You normally have a nice lordotic dorsal bend to your cervical spine, and when it's leaning forward, that's a red flag here. There's usually going to be some kind of X-ray finding of either a bone or ligamentous injury, and then these are players who are witnessed doing a lot of spear tackling. And so those four findings together are a pretty big contraindication to let somebody go back to playing football, just because there's a high incidence of permanent neurologic injury that has been seen in patients studied with this finding. Burning hand syndrome, this is another thing that's been described. And typically this is either in the upper extremities, arms or hands. Sometimes it can be seen in the legs. And it's differentiated from a stinger burner because both arms or both legs are affected. This is again going to be a red flag for more serious injury, possibly a spinal cord injury. And we want to treat these players as having a spinal cord injury until further evaluated. Clipable file syndrome is something that we see occasionally, and this is going to be a congenital malformation of the cervical spine. Basically, it's a failure of segmentation where the vertebrae don't really separate as the child is developing, or as the neonate is developing. So this is something people are born with. There's two classifications here, the torg classification. Type 1 is the more serious issue, and that's when a bunch of vertebrae in a row are fused together. And what that ends up doing is creating a large fusion mass, sometimes up above, some are fused, and sometimes down below, or both are fused. And that causes a pretty strong lever arm kind of on one segment there. And that can cause some very serious injuries. Torg type 2, that's usually when either one or two segments are fused together. So while you have some stiffness across those levels, it's not as much of a lever arm, and usually not a contraindication for contact sports. So this X-ray would demonstrate a torg type 1, where you can see here all these vertebrae are fused together, and it looks like probably C3 and C2 are fused together, or maybe C1, C2 are fused together as well there. So you're going to have pretty strong lever arm above and below, and that can almost like breaking a branch. It can snap right there in the middle. Toric type 2, here you can see just the 5-6 vertebrae are fused together. So really that's not going to cause too much of an issue. There can also be congenital malformations of the odontoid or the C2 vertebrae. Odontoid hypoplasia is basically where the dens fails to form. And so there's going to most likely be some increased instability there at the C1, C2 junction. Odontoidium is basically where the tip of the dens doesn't really form with the rest of the dens or the C2 vertebrae. And so that also might lead to some instability there. There's usually some cartilaginous or fibrinous scarring there that does provide some stability though. Spina bifida occulta, this is actually pretty commonly seen. That's just where the posterior elements or the lamina fails to fuse completely. Most of the time, the actual stability of the spine is not affected, and this is not a contraindication in any kind of sports usually. So here are the more serious injuries are going to be unstable fractures and dislocations of the cervical spine. So going back in history, football used to be a very dangerous sport. Back in the 1959 to 1963, there were 78 cervical spine injuries resulting in 16 deaths and 69 subdural hematomas resulting in 28 deaths. So those are pretty crazy numbers for us to be seen in a organized sport. And the funny thing is, players who had pads and helmets at that time were actually the ones more likely to be injured. So they realized there was an issue there and started making some advances in helmet technology. And then the players realized they can hit harder and start spearing people without hurting as much. And what that led to is an increase in more serious injuries. And so there was actually from 71 to 75 a pretty big spike in serious injuries, and 52% of those permanent quadriplegia injuries were because of players spearing each other. And I think I'll get into it in a couple more slides, but in 1976, that's when they officially banned spear tackling in organized football. So spearing, most of you guys know what that is, but it's basically where somebody lowers their head and charges head on into the player they're tackling. Problem is that your cervical spine is much more, it's built to distribute stress in the normal lordosis, and when you straighten out that normal lordosis, all that axial load goes straight through the spinal column. And so, as you guys are aware, coaches should always be telling players, tackle with your head up. You should be looking forward when you're making your tackles. So they banned spearing in 1976. There were a lot of changes in the national standards for especially football and hockey equipment around that time as well. This became a much more publicized issue. Athletic trainers, coaches became more aware of things that needed to be taught and watched for. Tackling techniques changed. The majority of these injuries, and really cervical spine injuries in general, are seen in defensive players, and that's because they're the ones making the tackles, whether that's the defensive linemen, defensive ends, or linebackers most frequently. So in 1976, pretty crazy number, there was a high of 36 quadriplegic injuries that year in football. Now that number's down to between 1 and 6. And so from the high in 76 to, I think the last year I have in this data was 1995. It's not too current there, but they saw a 65 to 70% decrease in injuries in that time span over those 20 years. Moving on to how we evaluate these players in the field. So obviously we've got the spine board, and the big issue here is going to be, how do we approach stabilizing the neck? What do you do with the helmet? What do we do with the face mask? How do we transition this player from the field to the spine board in a safe manner, and making sure that we have all the necessary equipment available? Obviously, the first thing we're going to think about here is, is this player breathing? Do they have normal pulse? That should always be the first thing, is the ABCs, but you do need to maintain cervical spine precautions, especially in a player who's altered or unconscious. Upper cervical spine injuries, that can cause injury to the diaphragm, the C3, C4, C5, innervate the phrenic nerve, which allows for breathing. So, if they have an injury and they're usually, this would be somebody who's paralyzed, but if they've got a complete paralysis at one of those levels, they can definitely have some respiratory compromise. Lower thoracolumbar injuries, you can sometimes see sympathetic nervous system issues, and that can lead to neurogenic shock, which would be low blood pressure, but also low heart rate. So the first thing, we think about after, making sure that your airway breathing circulation is okay, is going to be head control. If you're out there, moving a player's neck around and they're unconscious, that can end up in some pretty serious consequences. So usually it's recommended to apply a little bit of gentle longitudinal traction on the helmet just to help immobilize their neck. There are very few contraindications to removing the helmet on the field. Really, that would only be if there is a issue getting the face mask off, or if the airway could not be adequately assessed or controlled after the face mask was removed, or if the patient's neck or head does not seem like it's adequately immobilized, through the helmet. Sometimes these players will be face down. Rotating them to a supine position is necessary, but it's going to require multiple people to make sure that the head, the neck, the shoulders, everything is immobilized as you're flipping that patient to a supine position. If the player is already supine and you're trying to get them to the spine board, again, that has to be done very carefully. Multiple people locking arms underneath the player to hoist them onto the spine board with the head secured. Face mask removal, that's going to be probably the first thing you do after you assess the ABCs, is getting that face mask off if the patient is unconscious or altered. Shoulder pads and helmet should be left on, limits flexion and extension of the neck. And actually, if you take that helmet off and leave the shoulder pads on, it's going to hyperextend the neck, which can cause some serious issues. You got to make sure you do a proper neurologic exam in a patient where you're concerned about a possible spinal cord injury. You want to be checking, all of the muscle groups, doing a full motor sensory exam. Helmet removal should ideally be performed at a medical facility after a X-ray is taken to make sure there are no serious fractures or something that could result in some significant instability. That's usually going to be first things first, the face mask, that's usually off by that point, but then the chin strap, then taking out the ear pads, and then spreading the helmet open to get it off the head without causing too much stress. Who goes to the medical facility? Anybody with an altered mental status, obviously anybody unconscious. If they're having persisting neck pain or tenderness, even if you think it's just a bad sprain, that's something they probably need to have an X-ray to further evaluate and make sure there are no fractures there. Anybody with a really stiff neck where they're having trouble doing any kind of rotation or flexion and extension probably needs to be seen in a medical facility as well. And then of course anybody who is exhibiting symptoms of a spinal cord injury, and it's a little bit up in the air whether steroids are something that's beneficial or not. We tend to still give IV steroids if there's concern of a spinal cord injury, but the data in multiple studies is a little bit inconclusive if there is a benefit to it or not. Fractures are going to typically present with pain, and these patients are going to have a lot of neck pain, a lot of stiffness. Usually, they won't actually have a neurologic deficit unless it's a very unstable or severe fracture. On X-ray, you can usually see some prevertebral, or here at the front, soft tissues in front of the spine, you can usually see some swelling that's appreciated on X-ray if there is a fracture. And even if it's an occult fracture, that might be the only finding is some soft tissue swelling anteriorly. X-rays, you're going to want to get a few views, including flexion and extension views, to rule out any kind of dynamic instability. If you're still concerned and the X-rays look fine, a CT scan is usually going to be your best bet to assess bony anatomy and see if there is a fracture that's just not showing up on X-ray. And if you're concerned about any kind of posterior ligamentous disruption or if the patient is found to have a fracture, usually an MRI is indicated to assess that posterior ligamentous complex, or if the patient is exhibiting persistent neurologic issues or radiculopathy, an MRI is going to be warranted to assess for a disc issue or stenosis. Atlas or C1 fractures, this is going to be from an axial load to the neck or cervical spine. That's something you would see with spear tackling, for example. A third of these fractures are going to be associated with a C2 or DINS fracture, and there's a 50% chance that there's going to be some other kind of cervical spine injury concurrently. Really, there's not too much of an incidence of neurologic deficit with these atlas fractures just because the spinal canal is so wide at that level. You can have vertebral artery injuries, which could then result in a neurologic injury or brain injury or stroke potentially even. This would typically be treated with a rigid collar, depending on how much instability there is or how severe or displaced the fracture is. This might result in a fusion, either from the C1 level down or potentially to the occiput. Odontoid fractures or C2 fractures are going to be most commonly from a hyperflexion injury of the neck, and a type 2 injury is going to be the most common, where you see the base of the DINS or the base of the odontoid fractured. These are usually unstable injuries. These are something that used to be treated in halo vests for extended periods of time. Most likely now this would be treated in an unstable fracture with a posterior cervical fusion. You can also treat it by placing a screw anteriorly, which is a little bit trickier and actually not as commonly done as it used to be. Clay shoveler's fracture, that's basically a spinous process fracture, which you can see here of the C7 vertebrae, and that's again going to be from a hyperflexion injury. We see this in weightlifters, football players. It really is actually a stable injury despite usually having quite a bit of displacement there. Usually we'll treat this with a hard collar until the fracture starts to heal. Facet dislocations are going to be from a simultaneous flexion rotation motion to the neck. Basically what happens is the facet above will slide up and over the facet below and usually become locked. And what that usually shows up on x-ray as is about a 25%, sometimes more, anterolisthesis or shifting forward of the vertebrae above. While these are often stable, they do require treatment, and whether that's immobilization in a hard collar for an extended period of time, or if there's a significant amount of displacement, that can often result in surgery, whether that's placing a halo vest for an extended period of time after it's reduced with traction, usually in the ER, or a posterior fusion, depending on the amount of displacement. Compression fractures, these are going to be involving the anterior aspect of the vertebral body, and usually that's again going to be from a flexion force. This is something where if you see this in an athlete, you're probably going to want to get an MRI just to assess for any posterior ligamentous disruption. And if there is a significant amount of posterior ligamentous disruption, this would be an unstable injury, and this would usually require an anterior cervical fusion if there is that posterior disruption. Otherwise, if there's not, this is something that we can usually treat in a hard collar and just give it time, and usually it will heal up. Burst fractures, these are going to be involving both the anterior and the middle column of the vertebral body. And this can often result in bone being retropulsed or forced backwards into the spinal canal, leading to canal compromise. This is going to be a more serious injury typically than just a compression fracture because of that canal compromise, and this will often require surgery, whether it's anterior cervical fusion, or sorry, anterior or posterior cervical fusion. Moving on to spinal cord injuries, this is going to be usually from two mechanisms. So there's the transfer of energy to the spinal cord, which is going to cause a direct impact to the neural structures. And then there's a secondary inflammatory response which can cause some vascular compromise and cause further damage. And that's where the steroids come in, come into play. Is the thinking is that the secondary injury from the inflammation and from the vascular effects can be minimized, hopefully, from the anti-inflammatory effect of the steroids if given within, a time frame, usually within 8 hours of the injury. So characterizing spinal cord injuries, there's complete injuries and there's incomplete injuries. A complete injury is going to be absence of any motor or sensory function below the level that the injury is present at. So if a bulbocavernosus reflex is present, which basically is when you pull on the Foley catheter, if there is an anal spasm, that signifies that there is no more spinal shock, which can be something that is seen right away after an injury that kind of muddies the diagnosis. So if they have that bulbocavernosus reflex, that means spinal shock is over, and you can really assess the level of the injury and whether it is a complete or incomplete injury at that time. So you typically see functionally the motor improvement one level below might improve a little bit in 80% of victims, but when we get to 2 or more levels below, there's only typically motor improvement in about 20% of those patients. An incomplete injury is when there's going to be some form of motor or sensory function existing below the level of the injury. And sometimes maybe that is just saddle sensation or groin sensation, because sometimes the sacral nerves are still working a little bit. Let's see here. The chance for functional recovery is much, much higher if it's an incomplete injury compared to a complete spinal cord injury. The different kinds of spinal cord injuries, central cord syndrome is going to be most common. We see this usually in older patients who have arthritis, who have stenosis, and this is going to be a hyperextension mechanism. Usually presents as a quadriplegia. However, the upper extremities are typically affected more than the lower extremities are. And these patients tend to do pretty well and usually get some recovery back. Anterior cord syndrome, this is going to be a little bit more of a serious issue. This is going to be a complete motor deficit below the level of the injury, but sensation and proprioception and vibration sensation, that kind of thing remains intact because those are all in the posterior column of the spinal cord. These patients typically do not get much of their strength or motor back. So when do we bring players, back out onto the field? Depending on the injury, there's a lot of things to take into consideration. Just the kind of the range of motion assessment, that would involve, just seeing how much motion they can do, looking side to side, looking up and down, doing things like the Sperling's maneuver, where you have them tilt their head to, the side, the affected side, and if they have reproduction of symptoms going down the arm, that would be a positive Sperling's test. So that might be a contraindication to keep them out longer. Head compression test, just pushing directly axially onto the head and seeing if they have pain with that maneuver. Then obviously any residual neurologic deficit, weakness, sensation, you're going to be wanting to keep that player out for longer until more workup, or at least more time to see if that passes. So stingers, typically those players are good to go back with normal strength, full range of motion, no more radicular symptoms or paresthesias going down the arms. Cervical strain, you're going to typically immobilize that, as long as they're having some symptoms. You want to make sure that the x-rays are fine. If they have any kind of neck pain, you usually want to get an x-ray just to rule out any kind of a more serious issue there. Once their neuro exam is normal, once they have full painless range of motion, they're good to go back. And as long as they have some kind of rehab, physical training or physical therapy or personal training to kind of work on those muscles in the shoulder girdle and cervical muscles, the re-injury rate is typically about 17%. So it's not a real serious injury, but there is some recurrence. So the Watkins scale, that's something that we use when looking at transient quadriplegia or patients that have neuro findings and they end up having stenosis. This is basically a point system. I'm not going to get too much into it, but it involves, where the neurodeficit is, whether it's one arm, both arms, or even if it's a transient quadriplegia, that's going to be more points, and then quadriplegia, that's going to be the most points for the neuro section. How long this neurodeficit lasts, whether it's 5 minutes to more than a week, that's going to be increase in points. And then the stenosis of the spinal canal. So if the canal is wide, more than 12 millimeters, that's going to be 1 point, all the way down to a more narrow spinal canal, 8 millimeters or less, that's going to be 5 points. So another, Dr. Torg, he kind of put out contraindications to return to play, and he decided that anybody with congenital stenosis, so anybody with that more narrow spinal canal, along with some form of cervical instability or disc disease seen on MRI, or abnormal spinal cord signal seen on MRI, or a patient with stenosis lasting for longer than 36 hours, those are all patients that you probably don't want to allow to go back to playing. If they have more than one recurrence of an issue and they have stenosis, again, that's probably somebody who you're going to want to keep out of play. Congenital abnormalities, so those Clipable file patients, for example, that we talked about, the type 1 patients, that's usually going to be a contraindication for going back to any type of sport if they have those long congenitally fused vertebral segments. The type 2 Clipable file patients, where they maybe have 1 level or 2 levels, those patients are going to be kept out if they have any kind of motion limitations on examination, or if they have occiput to C1 congenital abnormalities, or if there's any kind of instability or degenerative change seen on their imaging. So the Watkins categories that are minimal risk, meaning low risk to send back to contact sports, are going to be bone spurs seen on X-ray, stingers, burners, disc herniations that maybe showed up on MRI, but the patient's now asymptomatic and no longer having issues. Fractures of the lamina, spinous process, those are usually fine once they heal to send them back to play. Or foraminal stenosis seen on MRI, and that's not the spinal canal that's narrowed, but the neuroforamen that's narrowed. And so those patients are going to be the patients who have usually radicular symptoms, so maybe pain or numbness going down one arm. And once that neurologic deficit resolves, just because there's foraminal stenosis there on MRI, usually those patients are safe to go back to sports. Moderate risk patients you want to think probably long and hard about at least when you're going to want to send them back, are patients with a lateral mass fracture, because fractures of the lateral mass in the cervical spine usually are going to result in some form of instability, or a fracture of the facet joint, same thing. Healed odontoid or dens fractures, as well as healed fractures of the C1 vertebrae. Those are going to be again something that you want to assess if they're having any residual pain, if they have any residual stiffness or range of motion issues. And if it's going back to like high level professional football or college football, that's probably something that you're going to want to think long and hard about sending them back in. Disc herniation with persistent radiculopathy, again, same thing. If somebody has kind of persisting symptoms, you're going to want to think twice about letting them go back while those symptoms persist. And sometimes patients will have issues that just last forever and they don't really go away. Peyton Manning played with radiculopathy for many years, and so again, this is going to be something that you're going to determine on an individualized basis. Extreme risk, that's going to be patients with a dens fracture, so that C2 odontoid fracture. Probably not ever going to send that player back into the football game. Os odontoideum, where that dens has not formed properly and there's some instability because of that, that's going to be usually a contraindication to any kind of contact sports. Clippable file syndrome, again, like we talked about, it depends how many levels are affected. That Torg type 1 Clippable file patient, they're not going to be going back to contact sports. A type 2, where it's just 1 or 2 levels that are congenitally fused, they may be able to go back. Anybody with a significant ligamentous injury, so you see a posterior ligament disruption on MRI, they're going to be at high risk for an additional injury. Facet dislocations, again, these often require surgery. That patient will not be going back, but typically, even if stable, there is still, there's still some risk of, additional injury there. So that's gonna be somebody you probably are gonna wanna keep out of going back to contact sports. Central disc herniations with significant narrowing of the spinal canal. Those are gonna be patients who you probably won't send back if it's a big herniation and there's a lot of stenosis because of it. And then fractures, again, if there's a fracture that, has, not healed completely or is still causing some persistent symptoms, those patients are not going back. And even if it does heal up completely, those patients are still going to be at higher risk. So you need to definitely take into consideration, on an individualized basis, is there any kind of residual instability? Is there some residual stenosis? And, think long and hard about sending that patient back into a contact sport. So kind of summarizing, burners, stingers, strains, sprains, these are pretty common. These players can go back once they have good range of motion, no more neck pain, and no more neurologic deficits. Bilateral arm or leg issues, those are going to be indicative of something else is going on here, whether that's a spinal cord injury or some kind of instability causing impingement on the central canal or spinal cord. Transient quadriplegia, this is something that will get better, but you have to determine when that patient is safe to go back to play. And like we talked about, these patients are going to be at a little bit higher risk of a recurrence, but there is a very low risk of like a permanent neurodeficit in these patients with transient quadriplegia. Fractures, dislocations, these are going to be the injuries that are most associated with permanent deficits. These are the ones that you want to treat appropriately, and probably these patients will not be going back to contact sports. Prevention, and so proper instruction, proper coaching, and even down to weight training, strength training for the upper neck and shoulders. This can all make a big difference in the rate of these injuries. Probably the biggest thing though, especially when we're talking about football players, is just reinforcing proper tackling technique. And never send a player back into play if they're having any kind of residual or persisting symptoms. All right, so let's see here. Not sure if there are any questions, Michelle.
Right.
All right, well, if there are any questions, feel free to type them in. Again, glad to have had the opportunity to talk to all you guys. And you can always, if you do have questions after the fact, if you send them into Michelle, she can always get them to me and I can get back to you guys if there are any questions later on. All right, thank you.
Perfect. We do have a question that popped up here from Kyle. And he asks, how do you manage the torque ratio for stenosis if they have a large neck?
So if they have a large neck, sorry, you said the torque ratio? It broke up for a minute.
That's correct.
So yeah, players with a large neck, so a lot of these football players, they're going to have a larger vertebral body, and that number is going to be falsely low. So they might have a torque ratio that's 0.6 or 0.7. And so, according to the torque ratio, that's going to be congenital stenosis. But in reality, most of those players actually have a completely normal spinal canal. So it's just that their vertebral body is disproportionately large compared to their spinal canal. In that case, the torque ratio is really irrelevant. And for the most part, we don't use that ratio anymore just because it does have such a low positive predictive value.
We have a comment here from Nadine, who's a frequent attendee, and she says, excellent presentation. Caroline asks, what is the best recommended procedure to immobilize the C-spine if the patient is lying prone?
So if the patient is lying prone, you're going to want to have somebody, you know, you want to leave that helmet on if it's a football player, but you want to have somebody stabilizing the neck, and then you also probably want to have at least 1 or 2 people on the shoulders, and then probably 3 or 4 people, you know, at the torso, at the waist, and on the legs. And so it's going to have to be a coordinated movement, basically flipping them, you know, from their stomach onto their back. And it'd probably be a good idea to have that spine board there ready so that, you know, when they flip onto their back, they're onto the spine board. But it's just got to be a very slow and coordinated issue. And the person controlling the head is going to be the one, you know, basically saying 1, 2, 3, counting out when you're going, because they're ultimately the one who, you know, is going to have, you know, the most risk at play here. And that, you know, probably, you know, in that case, if there is some kind of an injury like that, you know, hopefully there's, you know, a physician present. If not, you know, it could very well be, you know, an athletic trainer who's, you know, in that position, just depending on the, you know, the level of the, I guess, of the game.
I'll give you guys a couple more minutes here if you have any other burning questions. Very good. Well, thank you everyone for attending. And thank you to Dr. Snavely for an excellent presentation here. Very thorough, and gave us a lot of good information. I'm sure a lot of folks are going to be rewatching, looking for those quiz answers. Sounds like you hit a few of them, gave a few of them away. That's great. But thank you to everybody for attending. We had a nice large attendance here for a Tuesday evening.
Perfect. Well, thank you for having me.
Awesome. All right, everyone have a great night.
Bye-bye.